Welcome to a virtual midday symposium conference conducted at the 2020 ASHP Mid-Year Clinical Meeting and Exhibition. Dr. Grabe and I wish that we could be with you today, but due to unfortunate circumstances, the ASHP meeting obviously is going to be held online. So today's presentation is going to be Health System Pharmacy Challenges in Hyperkalemia, Bridging the Gap Between Evidence-Based Management and Real-World Practice. My name is Dr. Randy Fujit. I'm an internal medicine clinical specialist at the Denver VA Medical Center in internal medicine and infectious diseases. I'm also director of the Antimicrobial Stewardship Program. I am also a clinical associate professor at the Skaggs School of Pharmacy and Pharmaceutical Sciences at the University of Colorado Anschutz Medical Campus. And I'm joined today by one of the preeminent experts in renal disease, Dr. Darren Grabe. He is the Associate Professor of Pharmacy Practice, Chair, Department of Pharmacy Practice at the School of Pharmacy and Pharmaceutical Sciences in Albany College of Pharmacy and Health Sciences in Albany, New York. Our faculty disclosures are here for you. Dr. Grabe has none. I am on the Speakers Bureau of Takeda Pharmaceuticals. Dr. Grabe will be discussing a few off-label indications for Pateramir. He will be discussing hyperkalemia and sodium zirconium cyclosilicate in hyperkalemia. Our program information for today is provided by the North American Center of Continuing Medical Education, LLC, an HMP company, and supported by an educational grant from AstraZeneca. If you have any questions throughout the program, please type it in the chat box at the right of your screen. All questions will be answered in the last 10 minutes of the presentation. The learning objectives today are, first of all, to identify the socioeconomic consequences associated with hyperkalemia and how this data can be used to inform clinical management and pharmaceutical development strategies. We next hope to evaluate the clinical data surrounding current and emerging pharmacotherapies in hyperkalemia, including efficacy, safety, and mechanisms of action. And finally, to formulate strategies for bridging the gap between evidence-based management and real-world practices in hyperkalemia for optimization of outcomes and the minimization of risk. So let's start off with a little bit about the burden of hyperkalemia. The majority of my section is going to be talking about the pathophysiology of this disease and what is significantly involved in managing these patients. So let's start off with one of my favorite slides in today's presentation. This slide brings together basically the majority of mechanisms associated with the development of hyperkalemia in patients with chronic kidney disease and associated comorbid conditions. If we look at the center of the diagram, what you're first of all is going to see is that the development of hyperkalemia is most often the result of decreased secretion of potassium within the kidney. It's also redistribution of potassium within the extracellular and intracellular spaces. And then finally, an increased intake of potassium. So let's start off with CKD. If we look here, obviously, increased dietary intake. And unfortunately, this has to do with a lot of the typical dietary modifications in our patients with CKD. Sodium restriction resulting in decreased tubular flow, increased use of salt substitutes such as potassium salts, and obviously potassium-rich heart-healthy diets all can contribute to hyperkalemia in these patients. Metabolic acidosis can become a very serious issue in these patients as it causes a potassium shift from the intracellular to the extracellular space. Kidney transplants associated with renal tubular acidosis and/or the effects of the calcineurin inhibitors that these patients are taking has also been associated with increasing the potential for acute kidney disease. So these, unfortunately, coupled with some of the numerous comorbidities that so many of our patients suffer, primarily diabetes and cardiovascular disease. Now, if we move over to diabetes, you're going to see here that diabetics suffering from insulin deficiency and hypertonicity can unfortunately no longer redistribute acute potassium loads the way they used to, and taking it back into the intracellular space effectively. They also suffer, unfortunately, for hyporeninemic hyperaldosteronism. And this obviously significantly diminishes tubular potassium secretion. Moving on to cardiovascular disease, when we think of specifically those individuals with acute myocardial infarctions, CHF, these not only lead to decreased GFR, but also decreased urinary flow and tissue injury that unfortunately are associated with the various and significant amount of medications that we see in the final bullet points here. The beta-2 adrenergic agonists, the renin-angiotensin-aldosterone system inhibitors, and so forth. These medications all can become important etiologies of hyperkalemia. So moving on to the clinical and socioeconomic consequences of hyperkalemia, there are basically 5 bullet points here that I'd like to discuss over the next few minutes. First of all, what is the cost associated and the utilization of resources in the hyperkalemic patient? We're going to talk about a very unfortunate issue with these patients and the significant increased mortality as patients remain hyperkalemic. We're going to talk about one area that pharmacists can have a very important role in, is that in preventing hospitalization due to hyperkalemia. We'll spend a little bit of time talking about cardiac dysrhythmias. And finally, one of the main areas that I want to talk about today is the changes that our providers have for fear of either perceived or actual hyperkalemia in their patients, where patients may not be getting the most evidence-based therapy available to them because of this issue of hyperkalemia. So looking at the epidemiology and costs associated with hyperkalemia, we can see here from this study from the American Healthcare Research and Quality Institute, what we see, unfortunately, is that in 2014, when this was analyzed, 76,000 ED visits for hyperkalemia in patients with CKD. Unfortunately, nearly half of them required a hospital admission. Their average length of stay was pretty significant at 3.3 days and at a cost of approximately $30,000 per stay. Now, again, these are 2014 dollars. If we look forward in 2020, this is probably $40,000 to $50,000 now. So you can imagine the significant cost to our healthcare system associated with hyperkalemia. Now, patients with CKD are far more likely to have abnormalities in serum potassium. And looking at this relationship in CKD depends on the severity of the disease as well as the definition of the disease. Numerous studies have looked at varying definitions and with kind of disproportionate representations of patients with advanced CKD, and unfortunately had fairly small sample sizes within those reviews. On this slide, we see an impressive study by Luo and colleagues, which sought to examine the association between potassium levels and outcomes. But what you'll notice on this slide is that they're looking at this with a very narrow estimated glomerular filtration rate strata to understand how the burden of hyperkalemia varies by CKD severity. So looking at this study, we can see here that basically this is the time spent at a specific serum potassium level in patients with CKD. And if we look along the x-axis, you're going to see worsening of estimated glomerular filtration rate. So unfortunately, our patients with fairly normal, almost normal, I'll say, stage 1 CKD, what you're going to see here is that they spend approximately 15% of their time with hyperkalemia. But watch what happens as the patient starts developing more significant renal dysfunction. By the time they're down at 30 mils per minute, we're seeing that these patients are spending approximately 30% of their time. And if we look at this slide, especially right here, that about 2% of that time is at a fairly dangerous level of hyperkalemia. And we'll talk about in a few moments some of the issues associated with these higher levels. The bottom line is costs associated with hyperkalemia are significantly greater in CKD patients than in those without this comorbidity. So what about looking at the costs here in the United States? This was a very important study by Betts and colleagues, and it was looking at retrospective claims data analysis between the years of 2010 and 2014 again. What they did was take nearly 40,000 patients with CKD and hyperkalemia and then compared them with an additional 40,000 matched controls, matched on age, matched on renal dysfunction, matched on percentage of patients on dialysis, and so forth. And what they found was absolutely remarkable. They found that those patients with hyperkalemia had significantly higher costs associated with them. If we look at the 30-day costs or the first 30 days during this study, we can see here that these patients with hyperkalemia spent on average $4,128 more per 30 days. If we take that out to the full year, these patients were spending over $15,000, almost $16,000 in their associated healthcare costs versus the patient who did not have hyperkalemia. Moving one step forward, we can take this evidence a little bit further now. And what we can see here basically is that within the first 30 days of the study period, cases with hyperkalemia had a significantly higher number of mean emergency department visits, patient visits, and outpatient visits. So utilizing a significant greater amount of healthcare resources during this issue. In those patients, when they were required to be hospitalized, on average stayed greater than 1.5 days longer than patients without hyperkalemia, and probably one of the more significant issues, and again, another area where pharmacists can have a very large role, and that is prevention of readmission, because nearly half these patients had to be readmitted. So looking at this next slide here, we can look at the annual mortality rate by a study by Fitch and colleagues, and this paints a fairly grim picture, if you will, but obviously emphasizes the need for managing hyperkalemia in this population. This was a descriptive retrospective analysis of Medicare claims data, again, 2014. That seems to be the year that we did most of our hyperkalemia data. But this evaluated over 32 million patients, including those with CKD, with and without hyperkalemia. And what do we see? I mean, this is remarkable. If we look at the annual mortality rate, the first issue to obviously notice is those patients with hyperkalemia had a significantly higher mortality rate than the individuals without hyperkalemia. We also see, obviously, as kidney dysfunction worsens, we can see that the mortality goes up in all groups, but again, statistically significantly higher in those patients with CKD, to an overall average of about 25% mortality in the patient with hyperkalemia versus about 10% in those patients without. So again, very, very significant data and very important. Now again, taking this data one step further in the following slide here, we refer again back to that LUO data that I was describing earlier, the one with the very close monitoring of serum potassium levels and the patient's renal dysfunction. And what do we find here again? Well, the key to understanding the associations between serum potassium mortality, we can see here in this Poisson regression analysis, a definitive U-shaped model. And basically, this is looking at mortality incidence rate ratios. And what we can see here is, unfortunately, that in those patients within the reference range, compared to those individuals with levels of greater than 6, we see a 2.5-fold greater unfortunate mortality incidence rate ratio, suggesting a much higher ratio of associated mortality. But then again, what's interesting here is that this study also looked at hypokalemia, which also in itself was associated with higher mortality. So one of the big areas I think that pharmacists can have a huge role in, and that is the issue of preventable hospitalizations. And this is a Canadian study that wanted to basically explore the clinical characteristics, patterns of hospital use, and potentially preventable acute care encounters among patients with CKD and at least one hospitalization. So their measurement was those individuals who were admitted for ambulatory care sensitive conditions. And 4 of the big specific ones they would look for were patients admitted with hyperkalemia, heart failure, malignant hypertension, and volume overload. And again, these patients were not on dialysis, but had a degree of renal dysfunctions with an eGFR between 50 and 60 mils per minute. What they found was that 1 in 4 of these patients hospitalized with CKD was associated with an ambulatory care sensitive condition. And the biggest ones, heart failure and hyperkalemia. 2 significant disease states that we can manage in the ambulatory setting to a great degree and hopefully prevent some of these hospitalizations. So this becomes a very important area, I think, and Dr. Grabe is going to have a very significant discussion in some of the ways that we can hopefully prevent these hospitalizations. Now, no discussion would be complete with at least the small discussion on one of the biggest issues associated with hyperkalemia, and probably one of the most deadly issues associated with hyperkalemia, and that is the issue of cardiac dysrhythmia. Now, we can see on this slide, again, a lot of you are probably well aware of this issue, but just to briefly review, in normal kalemia, The cell membrane, as you can see here on the left-hand side of the slide of the cardiomyocyte, is polarized. It has a resting potential of approximately minus 90 millivolts. But when we start switching over to elevated potassium and leading into moderate hyperkalemia here, we can see the cell membrane becomes partially depolarized, bringing the resting potential closer to the threshold for action potential initiation. And basically, therefore, fast sodium channels are activated more readily, increasing excitability and conduction velocity. If we look down on the rhythm strip here, we can see that this is manifested as the typical well-known T wave peaking. And this is a result of mass ventricular cardiomyocytes undergoing synchronous early repolarization. Now let's take it to the worst point, and that is with severe hyperkalemia. Now we see that voltage-dependent inactivation of sodium channels and activation of inwardly rectifying potassium channels, leading to reduction in conduction velocity. And this can also render the cells quite refractory to excitation. Going back down to the rhythm strip, how is this going to manifest? Well, it's basically going to be demonstrated as a broadening, as you can see here, in these ECG complexes. Your P wave is significantly broadened, and obviously the entire QRS complex is broadened as well, and we can see significant conduction blocks. And obviously this can lead to rapid deterioration in our patients and arrest, cardiac arrest in these patients. So let's go back to our U-shaped curves here. And again, with the Luo and colleagues study, this is just looking at major adverse CV events, or MACE, according to serum potassium. If you haven't heard of MACE before, this is defined as a composite of arrhythmias, myocardial infarction, stroke, and heart failure exacerbation associated, in this case, with hyperpotassium. So again, what do we see? A very specific U-shaped curve, with those individuals in hypokalemia and hyperkalemia having in this case, 1.8-fold and approximately the same on either side of our reference range of potassium. Again, suggesting a very specific association with hyperkalemia and the issue associated with these cardiac events. So, one of the big areas I wanted to talk about today was the association of hyperkalemia and what we consider forced deprescribing, if you will. And this has been a major concern regarding the risk of hyperkalemia among healthcare providers around the world. They may actually defer from prescribing evidence-based options for very serious disease states: renal dysfunction, patients with heart failure, patients with other cardiac events and so forth, post-myocardial infarction, and unfortunately may lead to increased mortality due to not providing these medications to our patients. On this slide, you see two very specific registries. First of all, the Swedish heart failure registry, which looked at over 11,000 patients with reduced ejection fraction heart failure. All these patients had ejection fractions below 40%. They were in New York Heart Classification 1 through 4 and had a duration of heart failure for about 6 months. Only 40% of these patients, believe it or not, we're going to talk about the RAILS trial here in a few minutes, and its associated 31% reduction in mortality, but only 40% of the patients in this study were on a mineralocorticoid receptor antagonist, such as spironolactone. Their creatinine clearance of less than 60 was specifically associated with not using an MRA in these patients. Another review of real-world data, in this case of over 80,000 patients with heart failure in this review, they defined a treatment gap, that is, patients that were eligible to receive evidence-based therapy but were not on it for heart failure with reduced ejection fraction. And what they found was a treatment gap of 13.1% of patients with ACE inhibitors or ARBs, and a 16.8% treatment gap in individuals on it not receiving MRAs. And again, when the data was analyzed, renal failure was associated with the non-prescribing of these agents. Finally, from the European Society of Cardiology Heart Failure Long-Term Registry, this was a prospective observational study between May of 2011 and April of 2013. And in this case, over 12,000 patients, about 40% with acute heart failure and 60% with chronic heart failure, we noticed that in those patients with ambulatory heart failure with reduced ejection fraction, adherence to evidence-based therapies was pretty good with the renal angiotensin aldosterone and system inhibitors. And MRAs, again, only about 67%. But one of the big issues here is that the providers were not keeping them at the targeted dose for these agents to be most effective in reducing mortality. Only 30% of these patients were at targeted doses. And we have numerous other studies that have also indicated that the occurrence of hyperkalemia led to these very important drugs, unfortunately, being discontinued in up to half of our patients. And what's even more worrisome is maybe the potassium was corrected, but once discontinued, 75% of them remained off therapy at 1 year. So again, denying our patients evidence-based therapies over fear of hyperkalemia. So recently we've had the introduction of novel potassium binders. Things have come a far way since Kxalate. And we have drugs such as Pateramir, or again, the sodium zirconium cyclosilicate. These may actually mitigate some of the hyperkalemia associated with these therapies, especially in CKD populations, and allow for greater overall use of these proven agents. So this illustration, and I do have to give Dr. Grabe some kudos for identifying this one for me, is such a wonderful graph because this is the association of serum potassium with all-cause death, but demonstrates the potential if we can actually correct that dyskalemia. So this illustration is from the most recent Journal of the American College of Cardiology. It's a state-of-the-art review for abnormalities in potassium and heart failure and brings so many of these points home. On this graph, we see the similar U-shaped curve that we saw in the low data as we described, but again, this time suggesting a significant increase in all-cause death associated with both hypo and hyperkalemia. However, as you can now see, rapid correction and the ability to maintain patients in the normal kalemic range can significantly reduce this risk. Following the recommendations that exist for when to reduce or stop the renin-angiotensin-aldosterone system inhibitors or MRAs and so forth is appropriate for the short term. But again, it is important to reintroduce these agents as soon as possible, obviously while monitoring potassium appropriately. And this is where I really feel that potassium binders may have a significant role in allowing us to continue using this RASI therapy, which would be discussed in significant depth by Dr. Grabe. So let's talk about some of my favorite areas, and that is obviously the pathophysiology associated with hyperkalemia. Now, potassium handling, as it says on the slide here, what is normal? Well, if we look at potassium, it's the most abundant cation in the human body. 98% exists intracellularly, 2% extracellularly, and it has about a 30-to-1 concentration gradient. So we can see here the intercellular cation is approximately 120 to 153 milliequivalents per liter, with the extracellular, what you commonly see, 3.5 to about 4 milliequivalents per liter. So we take a 70-kilogram gentleman, he has approximately 4,000 milliequivalents of potassium on board, with about 65% of that being extracellular. And if we think about typical doses for a potassium supplement, this kind of brings to point, when you're giving 20 milliequivalents 3-4 times a day, what happens to that potassium? And the body is incredible in its ability to handle potassium, and we'll talk about that here in a few seconds. But the average US diet, unfortunately, is only about 40 milliequivalents per day, far less than the recommended daily allowance of 90 to 100 milliequivalents per day. So if we see here on the right side of this slide for oral intake of potassium, approximately 100 milliequivalents, the vast majority portion of our intracellular potassium is in muscle cells, associated with movement and obviously action potential and so forth. Liver cells and RBCs make up approximately 200 milliequivalents apiece, but this brings up an issue. When we see lysis of red blood cells leading to hyperkalemia, it's because they have such a large concentration of potassium within the cell. But of that extracellular fluid holding about 65 milliequivalents, pretty much constant, unless we have some of the issues that we talked about, especially renal dysfunction, about 92% of that GI intake will be eliminated in urine, where stool will be about 8 milliequivalents. So let's talk about how does this all occur, and how is potassium actually excreted? So if we look at the bottom of this slide here, you're going to see after filtration from the glomerulus, the majority of potassium is reabsorbed in the proximal tubule and thick ascending limb, and very little actually reaches the distal portions of the nephron. So you can see here again, 2/3 in the proximal tubule is reabsorbed, 25% more is reabsorbed in that thick ascending loop. But it isn't until the distal convoluted tubule where we see majority of action occurring with some of the elimination and so forth. And we're going to spend a significant amount of time talking about that cortical collecting duct, especially early portions of the collecting duct, where the majority of potassium is excreted. So no talk would be complete without a little bit of a discussion of the distal convoluted tubule. And here we can see the majority of drugs that actually have therapeutic interventions associated with that are ACE inhibitors, are ARBs, renal inhibitors, aldosterone antagonists, and so forth. But basically, how does the body eliminate potassium? Well, it responds to obviously a decrease in renal blood flow. Renin is then basically released from the juxtaglomerular cells of the kidney, producing renin, and which basically converts angiotensinogen to angiotensin 1, and then through angiotensin converting enzyme to angiotensin 2. Now, angiotensin 2 in serum is one of the primary mechanisms for the production of aldosterone. And most of you are well aware, aldosterone causes sodium and water retention, but potassium excretion. So with that, we see a significant increase in blood pressure, but the unfortunate response to this can be the potential for hypokalemia. So here we have basically talk a little bit about cation reabsorption in that distal nephron that we're talking about, primarily here in the distal convoluted tubule. And most of you that may not realize, but the cell that's responsible more for potassium excretion in the human body, or secretion, if I use the term correctly, is the initial collecting duct, and the cortical collecting duct is the principal cell. And what you can see here is basically the basolateral sodium potassium ATPase pump is responsible for the active transport of potassium into the principal cell. And this sets up a hyper K environment, if you will, that will set up the gradient for potassium excretion. But at the same time, the epithelial sodium channel here is going to bring the sodium into the cell. So that with chloride, which is reabsorbed paracellularly, we can actually manage potassium quite efficiently here in this distal portion of the nephron. So chloride is obviously, as I said, the more chloride that's absorbed, unfortunately, the less K that can be excreted. So how do we rev this up? Well, on the next slide, you're going to see here regulation of potassium excretion, and aldosterone is one of our primary mechanisms. Two very specific issues here. The release of aldosterone is controlled by angiotensin 2, but also by serum potassium. And what we see here is significant upregulation of that principal cell, where our sodium potassium ATPases are increased significantly, as well as the activation of these principal cells. So now, instead of having one pump bringing in 2 potassium ions, we now have 3 here, which is able to basically triple the amount of sodium being reabsorbed while increasing significantly the amount of potassium being secreted. So it's important to realize that this can be upregulated and deregulated. The kidney can reduce potassium excretion down to 10 milliequivalents per day, or in cases of significant potassium load or hyperkalemia and so forth, can increase potassium secretion by up to 400 milliequivalents per day. So let's talk a few minutes about at-risk populations for hyperkalemia. Most of you are well aware of the drugs that are associated with hyperkalemia. Drugs for hypertension, heart failure, diabetic neuropathy. Again, these are our renin, angiotensin, aldosterone system inhibitors, our angiotensin blockers, and so forth. These are very important evidence-based therapies that are available to us, but they need to be started slow and titrated appropriately to ensure that, especially in patients with renal dysfunction, that these are appropriate. So some of the strategies, obviously, very, very minute list here is obviously maximizing the dose of one agent, watching the patient's electrolytes, and then adding a second agent. Other options are start one agent and then start a second agent before reaching the maximal dose, and you're trying to get a little bit of synergy. Or in patients with more significant disease, starting two agents, but again, titrating the dose. But as I'm going to show you in a future slide, one of the most important issues is monitoring electrolytes during this process, and obviously having the patient adopt the stop hypertension diet. The RAILS trial. Everybody is well aware of the RAILS trial, probably one of the most significant trials in the treatment of patients with heart failure, and in this case, severe heart failure. This was a randomized placebo-controlled trial of spironolactone, started at 25 milligrams a day and titrated to 50 milligrams a day, depending on how the patient responded and especially potassium levels. But as all of you are aware, this study was terminated significantly earlier after it was determined that there was a 31% reduction in death. This pretty much set off spironolactone as a mainstay in the management of patients with heart failure. So what did we see? Well, Dr. Gerlink and colleagues actually went back and looked over time how this affected the use of spironolactone. And what we can see in his review here, that the spironolactone prescription rate per 1,000 patients went up dramatically in mid-1999 after RAILS was released, which is good. We're actually showing that we are applying bench medicine to the bedside, if you will. I kind of hate that term, but the evidence certainly showed that this worked, and we saw a marked increase in uptake of spironolactone. But unfortunately, we also saw a significant increase in hyperkalemia with the use of this agent. So again, everything has, unfortunately, its equal and adverse side effect, and with the use of spironolactone, this was one of the potential side effects that we worried about. What about other agents? Well, if we look at all of our antihypertensive medication classes associated with potential renal dysfunction and or effects on potassium shifts and so forth, we can see here that ACE inhibitors probably have the most significant effect. Its relative risk is a little greater than 1.5 times that of a patient not on medication. And then we can see the relative risk is slightly less for the ARBs, and this is at increasing K above 5. Potassium sparing diuretics, obviously not too significant a risk. Diuretics do what they do. They increase the elimination of sodium and potassium, and obviously are associated with hypokalemia. But here, again, K greater than 5 with the beta blockers, again, due to the shift from extracellular to intracellular potassium. If we look at a higher level, in this case, of potassium greater than 5.5, same exact things. Now, obviously, ARBs did not achieve statistical significance here, but again, the ACE inhibitor, potassium-sparing diuretics, and beta blockers were all associated, unfortunately, with the development of hyperkalemia. So numerous trials have actually reviewed individual blockers and then the combination of these type of blockers, the ACE inhibitors, angiotensin blockers, direct renin inhibitors, and so forth. And unfortunately, we see the more you add, the higher the risk. 33 trials here, including the biggest or the vast majority of trials, were the ACE inhibitor plus angiotensin receptor blockers. Everybody's well aware of these data. Some had ACE inhibitor plus aliskiren, angiotensin receptor blockers, and aliskiren. Then one actually had ACE inhibitors or angiotensin receptor blockers or aliskiren. And unfortunately, in 23 of these trials, 9.6% or 2,188 patients developed hyperkalemia in the dual therapy group, compared with only about 1,800 patients in the monotherapy group. So again, showing a significant increase as we increase the number of agents that affect the renin, angiotensin, aldosterone system. So dual therapy here again, 55% increase risk of hyperkalemia. It can be pretty significant. But again, this is an area where pharmacists can have a very large role in managing these patients. And I've often talked with my fellows and residents and so forth that if you don't look for it, you don't know what's happening. And this is a very important study by Chang and colleagues that was looking at the proportion of patients who experienced hyperkalemia over 3 years by definition, their estimated glomerular filtration rate, and how often they had potassium testing done. Potassium greater than 5 was used as a diagnosis for hyperkalemia. But what we can see here is that, especially in patients with normal renal function, we see here that there was a significant increase in the presence or identification, if you will, of hyperkalemia in those patients that had at least 4 serum potassiums drawn per year. Now, again, not significant. Majority of these patients probably did not have substantial elevations, but as we progress through this, the patients who had 0 to 2 labs per year, we didn't detect it nearly as often as those individuals who were getting at least 4 labs per year. And in the case of patients with severe renal dysfunction with a GFR of less than 30, these patients were developing hyperkalemia 62% of the time when we were actually looking frequent enough for the disease state. So I'm going to end real quickly, get a little bit of an idea of how you would manage a patient with one of these issues. Let's take a 53-year-old gentleman, comes to you with CKD stage 3B. His estimated glomerular filtration rate is 34 mils per minute. He has type 2 diabetes, hypertension, dyslipidemia, and proteinuria. So again, exactly like the very first slide I showed you today, in patients that have, unfortunately, these very severe comorbidities that require these medications. So he is on an ACE inhibitor. He's on a potassium-sparing diuretic. He is on atorvastatin, aspirin, metformin, and linagliptin. The recent laboratory results show hyperkalemia with a serum potassium of 5.5. What would you do? So let's look at what the majority of people would do. These are actions taken in the clinical setting, non-emergency department, after hyperkalemia was identified. Depending on how high the K was elevated, an emergency department visit was indicated in 1.2% of patients with potassium greater than 5, about double that if it was greater than 5.5. I mean, this is kind of a misnomer. If this person had a K of 7 or something, this would almost always be an emergency department visit. The majority would repeat a K serum measurement to ensure that there was no laboratory error and so forth. Some would prescribe sodium polystyrene sulfonate about 5% of the time. Some would increase the patient's diuretic. We can see here nearly a 2-fold depending on the level of potassium. But here's where we start getting into trouble. And this is where we're going to have a significant discussion here in a few minutes with Dr. Grabe. We start de-seeing the ACE and ARB, and we see that, look at this, 25% of patients. We also see decreasing the ARB, another 4.8%, decreasing the potassium-sparing diuretics, half of the time in Ks of 5.5, and then again, decreasing the sparing diuretic, very, very rarely done because we do know this does not have as significant effect as we were shown in the previous slides. So with that, it's my absolute honor, as I mentioned, to introduce one of, as I believe, in the nation's experts in hyperkalemia and renal dysfunction, Dr. Darian Grabe, who will now basically discuss the management of hyperkalemia and some of the options that we will have in the future for these patients. I turn it over to you, Dr. Grabe.
Thank you, Dr. Fujit, and thank you for an excellent review of hyperkalemia and some of the issues surrounding that condition. And it really makes my job a lot easier to kind of push for some of my assertions and some of my beliefs in terms of how we should be shifting our thought process and how to manage hyperkalemia for patients from all sorts of different walks of life. As I get started here, I want to kind of talk about studies and what studies might you find if you looked. This was published a couple of years ago by Polaka and colleagues, and it shows the different types of studies that you might see, including randomized control trials, non-randomized control trials, and observational studies. These are all the sorts of interventions that one might take to help manage hyperkalemia in different settings. And if I point sort of just to the randomized controlled trials, I think it's interesting here, less than 2 years after the Pateramir agent was approved and just about where sodium zirconium cyclosilicate was approved, there were more clinical trials, randomized controlled trials, studying these agents in hyperkalemia compared to an agent that's been on the market since the late 50s, early 60s, and that is sodium polystyrene sulfonate. Clearly, this was published 2 years ago, and so since then, you can imagine what this figure would look like now. So again, I think the weight of the evidence is important here. If we talk about evidence-based medicine and how that influences our treatments and what we do for patients, I think that's an important point here, and I think it's really what I'd like to establish right up front. We have a number of current therapies, and Dr. Fujit talked about a couple of these. We have, obviously, for temporizing agents or agents that you might use in an acute setting for patients that really need intervention to kind of save their life. You have insulin and dextrose, beta agonists, albuterol in a nebulized way. And obviously, in significant cases in patients with kidney failure, you might set up a hemodialysis session to remove potassium from the body. Beyond that, there isn't much from a chronic management point of view. Clearly, sodium polystyrene sulfonate has been on the market for a number of decades, but more recently, we now have 2 additional agents to consider as far as our strategy is concerned, and that includes Pateramir and sodium zirconium cyclosilicate. So I want to kind of set up this picture of how you choose between those agents, what you would consider as a healthcare professional managing patients with this issue. So we'll start with the past. In my opinion, we have sodium polystyrene sulfonate. Many of you are familiar with this agent. It's still used to this day. It comes in a powder, suspension, enema form. It does have suffer from some availability issues in the past recent history. So it's not guaranteed that you might have access to this agent in certain settings. The dose is quite variable, in fact, 15 grams, anywhere from 1 to 4 times a day, which is an important point given the fact that we're going to talk about drug interactions. And now that influences what other therapies you might give or how effective those other therapies might be. The cost is still significant, which is surprising given an agent that's been on the market since the 50s and 60s. And it's, again, quite pricey, even in comparison to other drugs that have been around that long. I'm going to start with the story. There are a number of issues with this agent, and I'm not going to hide my bias against SPS for a variety of reasons. Number one, there's no real good, rigorous clinical trials to determine efficacy and safety. It takes several hours for it to work. It was real questionable utility in emergent hyperkalemia. It's sometimes combined with sorbitol, sometimes it's not. The efficacy of that agent compared to sorbitol or no sorbitol is in question, and in fact, what the impact of sorbitol is in and of itself as an agent also has issues. As presumably a number of drug interactions, I'm going to talk about that in a little bit of detail. And then finally, the mixing and dosing and palatability of the agent is less than optimal, I would say. The original study that got this agent on the market was one that was published in 1961 in the New England Journal. It was 32 patients. It was not a controlled trial. These were patients that all had kidney injury. They were all hyperkalemic. Hemodialysis is not readily available at that point in time. So really at the time, this is appropriate therapy given the circumstances and the limited availability of other interventions. The dose ranged and the therapy ranged in terms of how it was employed within these patients. So if you go back and review a study like this in a journal club setting, you can certainly question some of the controls and tell some of these patients were handled from kind of a uniformity point of view. Again, the dose ranged and the duration ranged quite substantially, and it was given in a couple of different ways, both orally and rectally. Ultimately, the reduction in serum potassium was measured to be about 1 milliequivalent per liter. Following that, there was more recently a retrospective analysis of 138 patients. So think about that time between 1961 and 2015 when this was published, and the time in between in terms of whether or not studies were done or not done. And there's not a lot there, to be honest with you. In this particular study, they looked at suspension with sorbitol compared to controls. And you can see that there is not much of a difference between the agents, the control patients versus the active treatment. In fact, the mean change was about 0.14 between the two groups, which reached statistical significance, but one would argue that maybe not clinically significant. Following that, we now get into some prospective studies. This is a small study of 6 hemodialysis patients. In essence, the drug had no effect on serum potassium in these patients. What it did do compared to placebo was sort of stabilize potassium. You can kind of see these lines are completely flat. They looked at patients with resin alone and resin compared to combined with sorbitol. And so in that regard, really just a flat line and not very impressive results. The next prospective study was in 97 patients with kidney disease. These are patients that were treated with the agent for 3 days. Reduction at day 3 was about 1.5 milliequivalent per liter, but it was coupled with a significant increased rate of adverse events, GI, including increased blood pressure. So you might imagine that an agent that exchanges potassium for sodium, that would be a reliable prediction that blood pressure might go up as a result of that. So again, it was not without harm, in my opinion. Next, and finally, is a perspective. And finally, we reach an opportunity to evaluate a real clinical trial here. This was a randomized, prospective, double-blind, placebo-controlled trial of 33 patients. So not a large trial. These are only patients with CKD with a mean GFR of 20. So stage 4 CKD, essentially. Their mean potassium level is 5.2, so just above the upper limit of normal, and in some labs, perhaps the actual upper limit of normal. After 7 days, there was a greater reduction compared to placebo of potassium level of 1 milliequivalent per liter. And again, coupled with an increased rate of adverse effects, and again, a small sample size. So not reliable evidence as a whole, in my opinion, to demonstrate an agent to be effective and certainly safe for our patients. Furthermore, more recently, the issue of colonic necrosis has come to light, and the FDA is focused on this for sure. There's a few small studies, and it's certainly clear that the rate of colonic necrosis is very rare, but does occur. And when it does occur, it is a significant event. It is not. It is associated with significant morbidity and mortality. So with an agent with questionable efficacy, not demonstrated over many decades, coupled with significant and serious adverse effects and ones leading to more significant morbidity and mortality, one really has to question whether or not this is a drug that you want in your pocket to use. The next issue, and I mentioned this, is drug interactions. Back in 2015, the FDA indicated that more studies need to be done with drug interactions with SPS. I have looked and I have not found much other than the 3 here, and that was related to quetiapine, lithium, and iron absorption, all of which were reduced. So the recommendation right now, if this agent is to be used, that you separate the drug by 6 hours on either end with other medications. And so early on, I mentioned that the dose might be as frequent as 4 times a day. And so that really makes it impossible to avoid drug interactions in patients that are administered SPS. And even just given once a day, that 6-hour time frame on either end is very challenging to administer this in patients that are complicated. These are not patients with one medication. These are patients with heart failure, with hypertension, with diabetes, and with kidney disease, all of which have multiple medications and suffer from competing comorbidities. So in summary, there's no rigorous clinical trials. It takes several hours for the drug to work. Questionable utility in emergent hyperkalemia. We've all seen this agent used in the emergency department. You'll see the stat order come to the hospital pharmacy for SPS, and one really should question that role at this point. The influence of sorbitol, I think, is questionable. There are significant safety concerns, and I mentioned the drug interactions. And so this image here on the right kind of talks about this. This is nothing new. They knew this in 1966. These investigators talked about the dangers of this therapy. And this is specifically talking about the issue of hypertension and its related concerns regarding sodium absorption and the subsequent consequences of that. So again, this is nothing new. This is something that we've known for many, many years. And there's an opportunity to change our thinking, to change our strategies, and to kind of move on and do better for our patients. So that enters into the discussion of the new agents. We have two, Pateramir, which was first to market, and more recently, sodium zirconium cyclosilicate. They are going to be likely placed in the same bucket as SPS, and they're likely going to be placed in the same bucket with each other as cation exchange resins, which I think is true, but not detailed enough, in my opinion. I think we need to know more. We need to understand how they actually work in order to choose therapy properly for patients with competing issues. So in summary, they are both obviously cation exchange resins. They are not absorbed. Pateramir exchanges potassium for calcium, where sodium zirconium cyclosilicate exchanges it for hydrogen and sodium. The primary effect of Pateramir is going to be in the colon. I'll explain why that is, as opposed to sodium zirconium cyclosilicate, which works throughout the GI tract. So clearly binding potassium in the GI lumen will lower serum potassium levels through the exchange, and ultimately that captured potassium is excreted in the feces. So let's explore a little bit more about how these drugs actually work. So the first one is going to be Pateramir. Pateramir is a molecule with several carboxylic acids. And so carboxylic acids will become ionized in a more basic environment. And so as the agent travels through the GI tract, it's going to eventually reach the colon, where the pH reaches a range 5.2 to 7.8, which is exactly the range where the carboxylic acids are going to be ionized. This becomes important because these salts are going to then counter NA cations that might be in the system. And those are a number of different basic amines, as well as metal cations, calcium, magnesium, sodium, potassium, and others. So that Coulombic attraction between oppositely charged species becomes irrelevant here. And so here we have the Pateramir molecule, the carboxylic acid component. One calcium ion is bound to two cross-linked polymer of these calcium carboxylic salts. So ultimately, this becomes important. Again, this is not an agent that's metabolized nor absorbed. So when we look at this in the gut, these calcium molecules are counter exchanged for potassium. For one calcium, two potassium molecules are gained and ultimately excreted into the GI tract. So just a bit of a simple picture kind of shows you how that occurs. If we look at the polymer chain a little bit more closely, what will happen here is the calcium molecule will leave, and ultimately you'll see two potassium molecules attached to either side of this polymer chain, leading to the excretion of the potassium in the GI tract and lowering potassium in the serum. All right, so this slide kind of shows you the end story of where the potassium is bound to this polymer chain of Pateramir. And while potassium, again, is not selective potassium ions, it is capable of sequestering other cations, such as magnesium, and as such can cause hypomagnesemia. It can also bind to other drugs. Now, when we switch gears and talk about sodium zirconium cyclosilicate, you'll see here the crystalline structure of this agent, which works differently than Pateramir. In fact, on the right, what you'll see is this agent with a sodium ion captured in the inner pore of this molecule. On the left, you see the crystalline structure with the different colored spheres representing the different molecules that are consistent with this structure. This is a potassium binder for hyperkalemia. Like I said, the mechanism is a little bit different. These exchange sodium and hydrogen for the potassium molecule. This inner pore, these are certainly attracted, but when it enters the GI tract, we recognize that the sodium ion is not necessarily held as tightly, which is actually what we want to achieve for these patients. So the sodium ion is going to escape the inner pore when it enters the GI tract. It turns out that potassium ion has more binding interactions with oxygen atoms, and that's because the potassium ion has a larger atomic radius and is bound within this pore much more tightly than sodium would ever be. And so because of that tighter bond, the potassium ion really becomes trapped. And that is an important feature, an important aspect of this. And this is not an interaction that is dependent upon the pH of the GI tract. So, which stands to reason why this agent is a little bit more uniform throughout the GI tract as far as removing potassium and a little bit more impactful. Circling back to Pateramir, so let's talk about what this looks like. So Pateramir, again, is non-absorbed, not metabolized. It's available in a number of different dosages. These are all powder packets ranging from 8.4 grams to 25.2 grams with the starting dose of 8.4 grams. This is a drug that can be taken with or without food. That's actually been studied in the tourmaline study. And you typically titrate it weekly. You start the 8.4 grams, you monitor potassium, which is pointed out by Dr. Fujit, that monitoring potassium levels is going to be important for these patients, even before they're on therapy, to recognize whether or not they're there. And the point of the fact that they live at potassium levels of 23% of the time to 2% of the time, if you're only measuring it once or twice a year, you may miss the time they're actually hyperkalemia. So more frequent monitoring, 4 times a year is a reasonable thing to do. It's an expensive agent. It's about $700 for a 30-day supply. But if you go back to the slide that Dr. Fujit pointed out in terms of the cost difference, in terms of what a event of hyperkalemia costs, a year therapy of Pateramir is actually going to be a cost savings actually for a hyperkalemia visit. Which is, I think, interesting, not to mention the potential benefit you might see in other comorbidities using ACE inhibitors or what have you. There are 3 primary trials that have, I think, cemented that this drug is effective. The Amethyst, the Opal, and the Pearl trial. The Amethyst trial was a patient population with diabetes and kidney disease. These patients were all on some degree of RAS therapy. And it was effective. It was clearly effective. I'm going to show you that graph in just a second. Opal was a patient population with CKD stage 3 and 4. These are patients who are all hyperkalemic, all receiving RAS therapy, and again, effective for patients with mild, moderate, or severe hyperkalemia. Pearl was a study looking at patients with heart failure. These patients all had an indication for spironolactone, but unfortunately were not able to use spironolactone given the concerns of hyperkalemia in them. And ultimately, what showed in this trial is that they were able to actually start spironolactone, gain the benefit that the RAIL trial indicated, and ultimately liberalize that therapy for those patients, and I think improve outcomes. And again, it was effective in that. So real quick here, Amethyst, this is, again, it shows it's effective. So again, within 3 days, the potassium levels, whether they're mild or moderate in severity to begin, all were reduced to the normal range throughout the entire year of the study. At the end of the trial, they stopped the agent. And so you see the potassium levels go up clearly upon discontinuation, not to the pre-study levels, but it does sort of kind of make you think about what your strategies would be for dosing from a daily basis to maybe some less frequent dosing strategy for patients following a year, and how do you maintain that? So those are some things that I think from a clinical point of view, we consider as opposed to daily therapy, and that actually may influence the cost of the therapy as well, and maybe make it more available for others. The Opal, again, these were patients with mild, moderate, or severe. Didn't matter what group. Patients all showed reductions in potassium early on and throughout the entire 4 weeks of the study. What's interesting about the Opal trial also, and I really enjoy this graph because it makes my argument easier. On the left-hand side of this graph are placebo versus Pateramir in the darker red bars. This was the patient population that required some adjustment in RAS therapy. So we talked about earlier the fact that these patients may not be on the optimal dose, or they may not be on a dose at all of therapy they should be on. Nonetheless, those patients that were getting placebo, 62% of them required some adjustment of therapy, which is unfortunate, as opposed to 16% on Pateramir. And so again, it allowed patients to stay on the therapies that they need to stay on. In addition to that, at the end of the trial, 94% of the patients receiving Pateramir were still getting a RAS inhibitor as opposed to 44%. So again, I think thinking beyond the management of hyperkalemia and moving on to the thought of these are agents that you would add as part of your strategy to manage underlying conditions such as hypertension, such as heart failure, and what have you, is an important feature. My analogy to this has always been if we have a patient that's on a diuretic for hypertension and they become hypokalemic, we showed how significant that is in the U-shaped graph that Dr. Fujit showed earlier. We need to fix hypokalemia. That is going to lead to increased morbidity and mortality. And what do? Well, we are likely going to be adding potassium supplement. No one really blinks an eye when that happens. You add a potassium supplement, you monitor potassium, and you move on. I think the same thing should hold true with potassium binders. Potassium goes up, you think about a potassium binder, or you maybe think about it before it happens because you don't really want people to become hyperkalemic. So that's the sort of change I think we need to make at this point, and this is the argument that I'm trying to make. Finally, the Pearl trial, again, these are patients with heart failure. These are patients, again, that were able to get on spironolactone at 25 milligrams a day, up to 50 milligrams a day, mirroring what Rails did, and again, demonstrated they were able to maintain serum potassium levels in the normal range, as opposed to what happened to patients that got placebo. Additionally, what's interesting is in the WEIR trial, you showed reductions in blood pressure as well as serum aldosterone levels. So you may actually could back off on other antihypertensives in patients that have high blood pressure. These are similar reductions, in my opinion, that you see with antihypertensives. So again, I think this is an agent that people are putting in one bucket. I think we need to kind of think a little bit more broadly with these agents. Let's talk about the drug interactions with Pateramir. This was a concern early on, and in fact, the package insert showed that a boxed warning showed that you need to separate these by 6 hours. What's interesting about that was a box warning in Pateramir, but did not appear as a box warning in SPS, despite the issues. And so they looked at 28 drugs in vitro, and then they filtered that down to 12 medications that they studied in vivo. And of those 12, 3 had significant interactions. So it was adjusted to separate this drug out by 3 hours on either end as opposed to 6 hours, which is a bit of a barrier to some extent, but I think it's not as a significant interaction with most drugs. The ciprofloxacin and levothyroxine and metformin are obviously concerns. You need to consider that in those patient populations. So in summary, Pateramir is a drug that takes several hours to work. Questionable utility in emergent hyperkalemia still. We do see electrolyte disorders. If you dose it too high, you're going to see low potassium levels. And because of the mechanism of action, you may in fact see hypomagnesemia. That was demonstrated in the trial, so you need to monitor magnesium levels as well. There are drug interactions, and so separating out the drug makes sense. And you can sort of adjust that depending on the therapy they may be on. It is a higher cost compared to SPS, but given the benefit on the back end regarding outcomes, I think it's a worthwhile investment. There are specific mixing and storage concerns. In the pharmacies, it's going to be stored in the refrigerator. Patients with a 3-month supply should be able to keep that in normal room temperature without any issues. But there are some mixing things that you'll need to talk to them about how to drink it and how much water to use and what have you. Okay, switching gears to sodium zirconium cyclosilicate. This is a potassium binder. It is not absorbed, nor is it degraded. Its primary effect is actually with the entire gastrointestinal tract, and it's available as a couple different dosing options. One is a 5-gram powder packet, and another is a 10-gram powder packet. The initial dose outlined in the package insert is to give 10 grams 3 times a day for up to 48 hours, and then beyond there, provide the patient with a maintenance dose. And that maintenance dose is going to range anywhere from 5 grams every other day to 15 grams daily. And of course, that's dependent upon the patient's potassium, whether or not you're able to maintain it within that range. And you titrate that weekly. So when you're starting that initial dose, you bring the potassium down. After that, your dose is going to be titrated weekly, and you're going to monitor potassium levels as a result of that. Now, what we have done a little bit different is to adjust that initial dose if somebody has not got a very high potassium, or we're making other adjustments. We may make some adjustments of that initial 48-hour time period and start them on a lower dose. And again, that's not in the package insert, but that's some of the things that we make some changes to it in the clinic. The 2 initial trials that were published include Harmonize and the Packham trial. The Harmonize trial was a phase 3 randomized double-blind placebo-controlled trials. These were patients that had persistent hyperkalemia. They were randomized to placebo or one of 3 doses of sodium zirconium cyclosilicate. It started off with a 48-hour open phase, and in fact, this 48-hour phase, I think, was what informed the dosing instructions that I just mentioned. Those that achieved normal kalemia in that first phase were randomized then to a 28-day study, and that was about 237, the majority of the patients that started the study. The results is that the majority of the patients were on RAS therapy. The majority had kidney disease. It was effective for mild to moderate hyperkalemia, and the adverse events were similar to placebo. They did note that as you push the dose to higher levels, that patients started to show some peripheral edema, which was fairly mild and actually treatable. In the second trial was the Packham trial. This was a phase 3 trial. It was randomized. It was a 2-stage trial, double-blind and placebo-controlled. These were patients with kidney disease. They had stage 3 kidney disease hyperkalemia. The serum potassium ranged anywhere from 5 to 6.5 milliequivalents per liter. This is a dose ranging trial, so they were looking to see what was the right initial dose. They had quite a few patients, 753 randomized to one of those doses listed on the slide. What they showed then is whether or not you can get to stage 2, which was, this maintenance phase, if you will. 72% of those that were in the first phase were then eligible to reach phase 2. And the majority achieved normal kalemia. The steepest decline they saw in the potassium levels were in the first 48 hours, and the adverse event profile was similar. 2 additional trials worth mentioning is the Spinowitz trial, which was a phase 3 open label trial, so it was a non-placebo controlled trial. These were patients, again, with stage 3 CKD with hyperkalemia. All of the patients had potassiums of 5.1 or greater. It was another 2-phase trial with the first phase being a correction phase to get that potassium down to the normal level, and then a maintenance phase beyond there. And you can see that the majority of patients, in fact, over 99% of the patients were able to get into that maintenance phase of this trial. These patients were primarily on RAS therapy with multiple comorbidities. There was 38% of the patients that went to the maintenance phase that did not complete for a variety of reasons. Some just simply discontinued therapy, patient choice, what have you. These are all outlined in the study details, but it was quite a range of reasons for this. Normal kalemia was achieved and maintained in the majority of patients in this trial. The adverse events were similar to other trials. They showed some GI-related events. They showed some hypertension in the patient population and peripheral edema, particularly with the higher doses. It was not severe in most cases, and often it was not actually related to the drug as indicated. but rather perhaps related to some of the underlying conditions, as these patients had, like I said, multiple comorbidities. The next trial was a dialyzed trial. This was a phase 3B trial, double-blind, placebo-controlled. These are patients with hemodialysis, receiving hemodialysis 3 times a week. And what they did is they demonstrated these patients had pre-dialysis hyperkalemia. So prior to that dialysis treatment starting 3 times a week, they showed that their potassiums were greater or equal to 5.1. What they did was they did a 4-week titration trial to kind of find the right dose for those individuals. And then after that, they looked at what the dose evaluation was, whether or not it impacted that pre-dialysis potassium level. So they randomized these patients to 5 grams daily of the medication compared to placebo, and those doses were giving on non-dialysis days, so the 4 days that they weren't getting dialysis. And the primary endpoint was to try to get a potassium level between 4 and 5. The majority of those patients that were on the sodium zirconium cyclosilicate achieved the primary endpoint. In fact, about 41% achieved the endpoint, compared to 1% that of the placebo patients. So again, fairly effective for a very ill patient population, and one that has no potassium removal other than dialysis for the most part. The adverse events were similar to placebo, and again, they included similar things that I mentioned: GI-related events, hypertension, and peripheral edema. This is the first trial. Again, you see here the red triangles indicating when the dose was given, and you'll see the potassium levels drop within 4 hours, actually, which is interesting. And actually, there was no potassium level drawn after that 3rd dose, which I find interesting. I'm not sure why. But ultimately, within 4 hours, that potassium level was coming down, and actually even before the 2nd dose. So that first dose of 10 grams had a significant effect on potassium, in my opinion. It was followed, obviously, the next day with 3 additional doses, and the potassium continued to drop into the normal range. Didn't matter what group you were in, if you had CKD, if you had heart failure, what your baseline potassium level was. The drug was effective, and very effective, in my opinion. The Pateramir trial, which is the second of the 2, this is the 2 different dosages compared to placebo. The gray circles represent placebo, the brown circles represent the 5-gram dose, and the red circles represent the 10-gram dose. And the red triangles indicate when the dose was given in relation to the time profile here. And ultimately, you see a dose response here with the 10-gram dose having a more significant effect, but both doses lowered potassium significantly. Here's the safety profile of the drug. And again, the doses that we're using in clinical practice will be 5 to 10 grams. There's not a 15-gram dose given or available. You'll see that the rate of edema with the 5-gram dose is similar to placebo, with a 3-fold increase, perhaps 6% incidence of edema in patients at 10 grams. Most of the time, we're maintaining people on 5-gram doses, so it's really not a concern. It is a concern in patients with sodium-restricted diets, and you need to kind of consider that as part of the total package. Hypokalemia, as you might imagine, with higher dosages, you start to see that. So that is a concern. And you need to monitor that, because we don't want to go to the other side of that U. We don't want to cause more harm than good. And so again, titration becomes important, and we're going to talk about why that's important and where the pharmacist can play a role there. Again, this is the Coruscant trial. Again, talking about the edema a little bit more. 7 of the 14 patients that got edema in this trial did not require any treatment. 13 of the 14, it was peripheral edema only, and they all completed the trial. So very mild edema, but something to consider. Hypokalemia were all mild and resolved with proper dose adjustment. So again, not something that resulted in a failure of the therapy. Drug interactions is different. So again, the danger of thinking about a resin, when people think about resins, they think about drug interactions in one way. That is, it's binding the medication and eliminating the medication in the GI tract. That is not the case with this agent, because it is different in terms of its mechanism. They looked at a number of different drugs here, both in vitro and in vivo. The change in the profile for these drugs was one of absorption, one of exposure. And it was related to the transient increase in gastric pH that's seen when this drug is given. So when we look a little bit deeper into the sodium zirconium cyclosilicate drug interactions, it's really a pH dependent mechanism. So for drugs that do not have any pH dependent absorption, it really is not going to have an impact on the absorption of the drugs. However, those that are administered within 2 hours of the drug on either end, those that are weak acids, you may see an increase in systemic absorption. And for those that are weak bases, you may see a decrease in systemic absorption. Examples of those drugs are here, furosemide and atorvastatin representing drugs that are weak acids, dabigatran representing a drug that is a weak base. Several drugs did not have any measurable interaction. Again, it really depends on whether or not the drug is administered at a similar time and whether or not it has a pH-dependent absorption pattern. So when we think about integrating these agents into clinical practice, there is some effort that we have to take to get these covered by insurers on the outpatient side of things. That's less of an issue now that the drugs have been on the market for a couple of years, but it is something that we need to think about, and we'll talk about some strategies that we have employed. Initially, the product was available to limited specialty pharmacies and select community pharmacies. That seems to be loosening up quite a bit these days, and I see them a little bit more available. Clearly, hospitals have very difficult decisions regarding their formularies in terms of the price points and what they're going to do. I think one of the drugs probably should be in the market or on the hospital formulary. It sort of depends on the hospital in terms of what they want to do. Pateramir requires some specific storage issues regarding pharmacies, and counseling is important for those patients. And again, talked about the initial dose of sodium zirconium cyclosilicate and how we might manage that. So let's talk a little bit about pharmacists. That's what we are, right? So we have three different things to think about regarding management. We have clinical considerations, we have the economics, and we have the patient. Regarding the clinical, in my opinion, these drugs are clearly efficacious. They're clearly safe. They clearly are hands down more appropriate to use than sodium polystyrene sulfonate. I think the evidence there, I think no one can argue the opposite to me that sodium polystyrene sulfonate is a more effective or safer drug. At this point in time, I think we need to move on, as I mentioned. There are some issues to consider regarding Pateramir and sodium zirconium cyclosilicate. As we pointed out earlier, there's always a price to pay. That price may be revealed as the drugs are used in other populations, but we do worry about some electrolyte disturbances. We do worry about edema with one of the agents. So again, those are things that we need to consider going into it and making sure we monitor our patients appropriately. The economics. When I look at this, I think about the patients and the outcomes in terms of the value-based interventions that we make and the outcomes that they achieve. And I think most people focus on the drug cost, the upfront costs, and rarely think about what the benefit is on the back end. And so I think the treatment costs, yes, initially are more, but the cost savings, the avoidance of an emergency department visit, and the ability to achieve outcomes for heart failure, CKD, hypertension, what have you, are more important. So again, it does require appropriate utilization. I'm not advocating that this drug is used or these drugs are used for all patients, but you need to select the patients that are going to benefit from that therapy. And clearly the patient factors are going to be important, whether they're going to take the drug. You can prescribe all the best therapy in the world. If the patient doesn't take the drug, it's going to be 0% effective. So again, we need to consider the patient, they need to be part of that decision-making process and the center of what we do. There are challenges regarding formulary decisions. Again, there's a lot of innovation, I think, that's here. And that challenge is, I think, an issue for formularies to be dynamic and be responsive to that innovation. And I think in terms of the definitions that the formularies make regarding the thresholds for that need to be considered. I think As we have more available evidence, and that evidence is available immediately, and I think thinking about who our stakeholders are, thinking about the number of comparative studies that are available, I think that is an opportunity for us to be responsive in our formulary decisions rather than reactive. Today, we are mostly driven by a class decision. We think about tiered co-payment systems, what co-insurance might exist, thinking about step therapy. You have to get through this hurdle to get to the next hurdle. Most often we're thinking about, getting authorization to prescribe therapy. My hope is that we get to a point where we're thinking about value-based design. That is, we value these therapies that have significant impacts on patient outcomes. We're thinking about personalized medicine, targeting drugs for patients that are going to work for the conditions they have, and not thinking about the individual condition, but the overall picture in terms of what they have in relation to their comorbidities. And so I tried to make this argument that this is not just a drug that we're treating hyperkalemia, but rather a part of a management strategy for significant underlying comorbid conditions. So part of this obviously entails transitions to care, coordination between different types of pharmacies, whether it be a specialty pharmacy, a hospital pharmacy, with the payer, the insurer, the patient, the prescriber. Those things should be working together. I'm not sure that they are all that well. I think we need, as pharmacists, work better together. I think we live in our worlds, whether we're a hospital pharmacist or community pharmacy or a clinical pharmacist. I think, though, that cross-talking needs to happen a little bit more frequently and be part of the decision-making process that ultimately impacts positive patient outcomes. There's some evidence to show that these agents or other agents in specialty pharmacy might actually be a benefit. There's some evidence by Visaria and colleagues that shows that when you are focused on their care, you show better adherence, better outcomes. And again, I don't think that's particular to specialty pharmacy. I think that's something that all pharmacists can do. And I think lessons that are demonstrated in this arena can be applied to a lot of different settings. And again, through proper support, getting the patient involved in their own care, effectively managing any adverse effects that come up, and making sure patients are getting reminders to refill their medications on a proper interval is going to be helpful for them. So we know, and I think we all know, that clinical pharmacy services improve outcomes. They reduce costs. That has been shown in a number of different settings and a number of different conditions, whether it's blood pressure, A1C, smoking cessation, what have you. I believe this is the next arena, or one of the next arenas that we need to think about. Those patients with CKD, those patients with heart failure in the community setting to help manage them and avoid hospitalizations and avoid poor outcomes. As far as the pharmacist's role in managing hyperkalemia, I think we have a prime role here in terms of identifying patients at risk, whether it be drug-induced or condition-induced hyperkalemia. I think we need to counsel patients about it. I think they need to know that that's a risk. I think when people think about potassium, they often don't think of the concern. They don't associate hyperkalemia with a negative outcome. They may hear about potassium, but we all know that potassium is a very dangerous substance, and if left untended, it's going to lead to mortality. I think we need to be better at motivating our patients to be involved in their care, and I think that we should be partnering with others, such as dietitians, to also help manage some of their diets. I didn't talk about diet much, but certainly that is a major contributor, as the graph earlier on showed, that what you take in from a potassium level, well, that can be modified. And we need to consider those diets as well to help manage our patients. So lessons learned, I think my bias is clear in that SPS really is limited. I think it has limited utility at this juncture. The efficacy is in question as multiple adverse drug events. In fact, a more recent clinical trial had to end abruptly because of the adverse event profile of the drug. Pateramir is an effective agent. Its use in emergency hyperkalemia is not approved. We have a fair understanding of the adverse events. They're minimal compared to SPS, and primarily GI in nature. You do see some hypomagnesemia, so that is something to be aware of and monitor for patient to see if they have a reduction in magnesium levels. Serious adverse events are pretty rare. There is an incidence of some hypersensitivity reactions, as you might imagine with any therapy, and we need to make sure we separate this by 3 hours on either end with interacting drugs. It is dosed once daily, so again, it's sort of a convenient dosing profile. Sodium zirconium cyclosilicate is newer to market. It has a number of trials also published, including an extension study, 11-month extension trial, which demonstrates that it is able to, over 11 months, maintain serum potassium levels in normal range. So it is effective both in the short term and the long term. It's effective certainly within a few hours. While it's not indicated for emergency management, some might see some initial use of that, particularly in the light of that SPS is often used in those scenarios. If it was me and I had a choice, I think I would choose sodium zirconium cyclosilicate over SPS in that manner. But again, it's not approved for that. Adverse events are different. They include edema, peripheral edema, hypokalemia is also evident. So again, taking care to make sure that those things are managed appropriately, I think is appropriate when you start this therapy, particularly as you raise the dose. So in conclusion, hyperkalemia is a common complication. I think that's been well established. It's common in patients with CKD, acute kidney injury, patients with diabetes, patients with cardiovascular disease. Much of that is related to sometimes their underlying therapy as well as it is associated with RAS inhibitor therapy. I believe that SPS has certainly questionable efficacy and safety concerns. And I believe that the newer agents are prime for introduction into the marketplace. They may require some help to get authorized for use, but I think we should be moving towards a different thought process in terms of how we manage our payer system. Thank you very much. Thank you, Dr. Fujit, and thank you for your attention in this program. I certainly appreciate it.
Okay, thank you, Dr. Grabe, for that exceptional discussion. So I guess we'll start getting to our questions today. We have quite a few and a significant number of people online. So again, this is excellent. The first question is, would you move away completely from using SPS and remove it from the formulary? I mean, that's obviously a very difficult area, and I'll start off with the first question, is that this drug has become unfortunately ingrained in so many of our treatment protocols for so long, but if we look at today's standards and so forth, this drug has not undergone any of the rigorous testing and so forth that we've seen with the final two agents that we'll be talking about today. But especially in the acute care setting, I think you have much more rapid, much more effective agents. I think you will see some obvious difficulties with removing it from the formulary in these patients. But again, it's very important to remember that this drug was not approved with a very substantial amount of rational data and so forth. And when we look at the secondary studies after those very small studies, if you will, we've seen that unfortunately we just have not seen that the juice is worth the squeeze at this point in the use of these agents. Dr. Grabe, your opinion?
Yeah, I mean, I think it's hard to get away from 50 years of muscle memory and kind of move into the next age. I think that my opinion is it's likely to remain on the formulary because of that. I think it's wise to have one of the agents on the formulary in addition to SPS for a couple of reasons. Number one, I think it's better. I think they're better agents for a variety of reasons. I think they're safer. But in addition to that, SPS has not necessarily been widely available at different points in time. And so if you run into shortage issues like we had in the last year or so at different points, you need to have this agent on board. And I think that will probably start to navigate people away from the agent and use a little bit more reliable agents for hyperkalemia.
I agree. And especially if we start looking at some of the adverse effect patterns and so forth. I mean, most of you are probably well aware of the issues of colonic necrosis and so forth in a hospitalized patient obviously can be disastrous. So again, I see the future similar to what Dr. Graves said, where we start utilizing these newer agents on the formulary and may see an end hopefully to SPS. Dr. Grabe, I'll give you this one. If a patient is end-stage renal disease and virtually no urine output, do ACE inhibitors or ARBs still cause hyperkalemia, or should we be able to give them without the risk of it got cut off, it got cut off without the risk, I assume, of hyperkalemia?
Well, it's a little bit difficult to ascertain sometimes the genesis of hyperkalemia in a hemodialysis patient. If they are anuric, have no kidney function, obviously the majority of their potassium burden is removed by the dialysis procedure. So often off dialysis, they live in a state of potassium accumulation until the next dialysis session. And so in that regard, we need to kind of be wary of that. A lot of the hemodialysis patients live at potassium levels that are considered a little bit elevated for the general population. That being said, the risk of hyperkalemia in ACE inhibitors and ARBs is reduced. We've seen that even with spironolactone being used in that population with no risk of hyperkalemia. So I still think that you can use them. We still do use them for blood pressure control and other reasons. So.
Absolutely, I agree completely. And as you mentioned, especially in our patients on dialysis, and we looked at the previous studies earlier in my portion of the discussion, whereas exactly as Dr. Graves said, the majority of these patients do unfortunately live between 5.1 and greater than 6 for sometimes a significant period of time, up to 5 to 10% of the time, and obviously placing them at significant risk, obviously, for some of the issues that we talked about, primarily arrhythmias and so forth. So if you remember the Ferraria data, and I do have to comment to Dr. Grave to giving me this individual graph and so forth that we have in the talk, you can see here that hazard ratio associated with poorer outcomes in these individuals on dialysis associated with their hyperkalemia. So unfortunately, I agree. Substantial number of these patients live in a hyperkalemic state and unfortunately can take such a small event to push them over. Next question is, the COVID-19 pandemic has moved inhaled medication use from nebulizers to inhalers. When possible, is there any data on using the MDI formulation of albuterol for the treatment of hyperkalemia? This is a great question, unfortunately, and something that I'm dealing with on a daily basis and so forth in a lot of our COVID patients. But no, unfortunately not. We're very unlikely to get the serum concentration necessary with an albuterol inhaler. And even with great technique in some of our patients, I do not believe that we would be able to get a high enough concentration to actually drive the potassium intercellularly. Dr. Grabe?
Yeah, I agree. I think it's difficult. I think that you're not going to get the right dose. You have to rely upon technique, and you have to rely upon a patient that's going to be willing to do that. And in some cases, those patients are not able to even close their hand, much less put up an inhaler to their mouth and get the right dose. So I think that would be unlikely to result in any positive outcome.
Okay, thank you. Can you comment on rectal administration of the newer agents? We kept SPS on the formulary for rectal use only because at the time there was no data for rectal administration of the other agents. I can start off briefly. I mean, these agents have not been tested rectally. I would be concerned that some of the formulation obviously would not have its mechanism of action in the lower GI tract, especially with Pateramir. Considering that these are oral agents, they were never developed for rectal administration, but nor was SPS. I mean, we never have seen any significant trials utilizing SPS in the rectal administration manner. But no, I mean, basically my bottom line is no, they cannot be utilized. Dr. Grabe?
Yeah, at least at this point. I mean, Pateramir is an agent that I wouldn't do that, and just based on its mechanism and where it works, it's not going to be something you would ever even consider. Sodium zirconium cyclosilicate might be something you could. A study would have to be done in order to make sure that there's something there, and that would be off-label unless the company pursues that formulation. And who knows? That may be something in their plans, but I'm not aware of any based on its mechanism, it certainly could be considered. But like these individuals have pointed out, having something in a rectal administration is good. I think rectal administration of most medications is a challenge for the staff. It's a challenge for the patient. If you have no other mechanism to control hyperkalemia, I think there's other mechanisms to do so. But right now, we have no data to support that.
Agree. Okay, I can probably get this next one. How much of a concern is hypercalcemia with Pateramir, considering the calcium may have to be given for arrhythmias? This is an interesting question, and again, I do have to state that Pateramir is not indicated at this point, although I know a lot of hospitals are using it off-label for the use of rapid correction of hyperkalemia and so forth. And especially when you're at the point where you're using calcium basically to correct that action potential in the cardiomyocytes and prevent significant arrhythmias. I have not seen data on this, but I do not believe that there would be, in my opinion, any significant effect, exactly as Dr. Grabe just mentioned, with the use of hypercalcemia in these patients. So I, again, defer to exactly what he just said regarding hypercalcemia in these events. Calcium should be given first line, and then obviously as these drugs are being used, especially in the acute care setting, that I do not believe there would be any significant impact. Dr. Grabe?
Yeah, I agree. I mean, I think the issue of acute medicine with these agents, particularly Pateramir, is not something that we're going to probably embark upon. The next question here is probably related to that as well, in the sense that, do these agents have a role in the inpatient setting, emergent hyperkalemia? What's interesting about that, is, SBS does. I mean, people are using SBS, in my opinion, off-label for emergent hyperkalemia and using it to supplement the initial interaction with the patient with, whether it's insulin or calcium infusions and what have you. So you may see that come to pass at some point where you see a little bit more use of it, but currently that's off-label at the moment.
Thank you. Okay, I guess we're down to providers are hesitant to start SCZ inpatient due to the lack of data. What's in the horizon for inpatient trials? Would love to see the current phase 2 trial expanded, end-stage renal disease on hemodialysis in the ED to decrease emergent hemodialysis. I mean, I'm going to agree with you. I mean, it's more of a statement than a question, but I agree with you. Those studies would likely should be performed. I don't know if that's going to happen, but I do agree. And especially as Dr. Grape just mentioned, I mean, one of the most important things to realize here is we've been using SBS off-label forever, and there is no difference, in my opinion, to utilizing these agents. Obviously off-label, have to make sure that you're very aware of that issue, but I agree. We would love to see some inpatient trials, especially in the acute management of hyperkalemia. Is the utilization of SPS in non-CKD patients efficacious? Dr. Grabe, I know this is one of your favorite areas.
I think it doesn't matter whether CKD patients or not. I think, I think SPS is just simply an inadequate agent at this point in time. I think we have better options. My bias is clear, and I don't think that's clouded in anything other than the fact that we have quite a bit of literature actually to support the use of these agents as opposed to SPS. And again, yes, more data is great. Having some data on the phase 2 trial would be helpful to understand its role. I do believe it's somewhat dichotomous, the types of questions related to this, because we have no data of SPS in a controlled way in these patient populations, yet it's still being used. I think the question is, yes, we want more data for these new agents. So it's this dichotomy nature of we don't have any data, but we're going to use it anyway, versus we want data for the newer agents, despite actually having a fair bit of data on its use at this point in time.
Great point. Excellent. Again, we're looking at, do you see studies on the horizon that compares the two newer agents in different patient populations, either calcium exchange in end-stage renal disease with Pateramir or sodium exchange in heart failure with Lokelma? I don't ever see a head-to-head trial between these two products. Most of industry has been really hesitant anytime to compare themselves to another active agent, obviously with the risk associated with potentially being inferior and so forth. So I don't ever expect a head-to-head trial to ever consider the use of these two agents and so forth. But Dr. Grabe, do you know of any? I don't believe so.
No, unless someone's willing to give out some grant money to study that, would be a fair bit of money to study that. That would be something that would be left to an independent researcher to some extent, or wait until obviously the drug reaches some degree of generic status down the road, but not at this point.
Agreed. Okay, well, one last question, and we have to quickly get through this here. Are there studies looking at outcomes in patients using the binders or not? There have been no outcome studies to date whatsoever. We're lucky we have the trials looking at efficacy and safety at this point. Those trials will probably be investigator-initiated, I believe, in the future, and very small studies. Dr. Gray?
There are a few that are, you can find these at clinicaltrials.gov. There are a few underway. We have no results at this point in time, but there are a few in heart failure and other conditions. So, I mean, I'm certainly excited to see those results, as anybody else might be. That is the key moment. Right now, what we're dealing with is an outcome of, can it fix hyperkalemia? And it does. They both do. The question is whether or not that contributes to better outcomes for chronic conditions. Those studies will be published. It's going to be a little bit of time. So some patience is certainly warranted.
Great, thank you. Okay, well, with that, that was our last question, and I sincerely want to thank our audience for taking the time out today on behalf of Dr. Grabe and myself. We really, truly appreciate you being a part of this very important presentation, and hope you enjoy the rest of your mid-year. So,
thank you, everyone.
You again.